Assalamu alaikum wa rahmatullahi wa barakatuh. This is the first lecture in prosthodontics for postgraduate students, and this is Professor Muhammad Mudaffar, and the title of the lecture today is Sequelae Caused by Wearing Complete Dentures. Well, time-dependent changes occur particularly at the interfaces between prostheses and their supporting and surrounding tissue. That's mean between the basal surface of the denture and the underlying ridge, and between the polished surface of the denture and the mucosa of the cheeks and lips. Long-term denture wearing is accompanied by consequences in local morphology plus functional and aesthetic changes. Well, the denture in the oral environment, uh, you know, direct mucosal reaction often result from mechanical irritation together, mechanical irritation from the denture, or together with accumulation of microbial plaque on the dentures, and beside that, the infrequent toxic or allergic reaction to constituent of the denture material. Well, long-term and continuous denture wearing day and night may have a negative effect on the residual ridge because of progressive alveolar bone resorption. Well, wearing a complete denture that function poorly may have a negative effect on the function of the muscle and nutritional status, particularly in older persons. Well, among the direct sequelae caused by wearing removable prostheses, whether complete or partial denture, could be mucosal reaction, oral galvanic currents, altered taste perception, burning mouth syndrome, gagging, residual ridge reduction, periodontal disease abutment in case of RPD, and caries for the abutment in case of RPD. Well, changes in the local mucosal morphology, surface properties of the prosthetic material, such as acrylic, it might affect plaque formation on the prosthesis. This is because of the surface irregularities or microporosities that may be found on the acrylic, which may promote plaque accumulation by enhancing both the surface area exposed to microbial colonization, and also it will enhance the attachment of plaque. Besides that, a plaque formation is greatly influenced by environmental factors, such as the design of the prosthesis and the health of the adjacent mucosa. Composition of the saliva also play factors, salivary secretion rate, oral hygiene, and denture wearing habit of the patient, especially those who wear the denture day and night. Well, the adverse changes that might occur on the mucosa may result from a prosthesis that promote irritation and infection of the underlying mucosa. Besides that, dental caries and periodontal disease in case of overdenture abutment, together with peri-implant gingivitis, as well as chemical degradation or corrosion of prosthetic material. Well, the interaction of prosthetic material and the oral environment. First of all, we have the surface properties that enhance plaque accumulation. First of all, the chemical stability. The PMMA or the polymethyl methacrylate is regarded as is chemically stable, especially when you follow strictly the manufacturer instruction in the curing. And beside that, if your denture is porous and rough, and this will promote the adhesiveness of plaque, and also the hardness of the denture is important to minimize plaque accumulation. Well, the chemical properties such as corrosion, toxic reaction, and allergic reaction are really rare, but if it happened, it may cause some response to the mucosa of the patient, whether to the underlying ridge or to the buccal or to the buccal mucosa or the lip mucosa. Well, the physical properties, as I said, if you made a denture with poor physical properties, this will cause mechanical irritation and it will enhance plaque accumulation. And the changes of the oral environmental condition, such as the health of the adjacent mucosa and the oral hygiene of the patient and the denture wearing habit of the patient, all these factors may enhance plaque accumulation and change in the plaque microbiology. Well, denture stomatitis could be classified into three categories. It depends on the extent and severity of the condition. So type 1, it is a localized simple inflammation or pinpoint hyperemia, and the type 2, it is a more generalized one. It involves either a portion or the entire surface of the denture covered mucosa, and the type 3, it is a composite of type 1 and 2. In addition to granular inflammatory hyperplasia, usually involve the midline of the hard palate and the alveolar ridge. So this is type 1 uh, denture stomatitis, which is characterized by simple inflammation or pinpoint hyperemia. And this is the type 2 denture stomatitis. It is a more generalized erythematous area involving either a portion or entire surface of the denture covered mucosa. And this is the type 3, which is a granular inflammatory hyperplasia involving the hard palate and the alveolar ridge. Well, various etiological factors of denture stomatitis have been reported, such as tissue trauma associated with occlusal discrepancies, denture defect, lack of oral and denture hygiene, denture age, a very old denture, and the continuous denture wearing habits. Well, the Candida associated denture stomatitis, where various species of Candida have been isolated and regarded as opportunistic pathogens that reside in the oral cavity of even those of those individual considered as healthy. As I said, it is opportunistic infection. When the immunity of the patient is decreased, it will cause the infection. Well, the Candida biofilm play a major role in the development and maintenance of denture stomatitis, and it is regarded as the most prevalent and clinically important lesion of the denture wearers. Well, the diagnosis of Candida associated denture stomatitis is confirmed by a finding of myceli or pseudohyphae in a direct smear or the isolation of Candida species in high number from the lesion, more than 50 colonies. Well, usually the yeast colonies of the Candida are recovered in higher number from the integular surface of the denture than from the corresponding area of the palatal mucosa. That means the fitting surface of the denture harbor more Candida than the palatal mucosa, so this will indicate that the primary source of the infection is the Candida adhered to the fitting surface of the denture rather than to the palatal mucosa. Well, the etiology and predisposing factor of Candida-associated stomatitis, as I said, the unclean denture and poor hygiene care are the major predisposing factor. Besides that, the tissue surface of the denture usually shows micropits and microporosities that harbor microorganisms that are difficult to remove mechanically or by chemical cleansing. Well, the pathogenicity of the denture plaque can be enhanced by simulating factors such as continuous denture wearing, poor oral hygiene, high carbohydrate intake, and reduced salivary flow. Well, the additional factor that modulate Candida-associated denture stomatitis include aging, malnutrition, immunosuppression, radiation therapy, diabetic mellitus, and possibly treatment with antibacterial. And well, as a summary for the factor predisposed to Candida-associated dental stomatitis, we have the systemic factors such as old age, diabetic, malignancies, immune defect, and corticosteroid and immunosuppressive drugs. And we have the local factors such as dentures, xerostomia, high carbohydrate diet, broad spectrum antibiotics, and smoking tobacco. Well, angular cheilitis, it is often correlated with the presence of Candida associated stomatitis, and it is thought that the infection may be initiated between the palatal mucosa and the maxillary denture, and from that area it spread to the angle of the mouth. So it is not right to say that it is the primary lesion. It starts at the angle of the mouth, but it is initiated between the palatal mucosa and the maxillary denture, and then it will be spread to the angles of the mouth. Well, the infection may be promoted by local or systemic conditions such as reduced vertical dimension or overclosure of the jaws, and nutritional deficiencies such as vitamin B or zinc, or iron deficiencies, anemia, or frequently a secondary infection caused by Staphylococcus aureus is present. Well, the upper figure show you angular cheilitis, and after a good treatment of the condition, the patient resolves as shown in the lower picture. Well, the management and preventive measure of denture stomatitis. Several treatment procedures could be used, such as antifungal therapy, correction of ulfatting denture, and efficient plaque control. And the most important thing is that an efficient oral and denture hygiene and correction of the denture wearing habit, because these are the major etiological factors of this condition. Well, treatment with antifungal agents should be used only on those patients, which is when it is confirmed by mycological examination from the lab, or those patients with burning sensation from the oral mucosa, and when the infection has spread to other side of the oral cavity or the pharynx, and then when there is an increased risk of systemic mycotic infection caused by debilitating diseases, drugs, or radiation therapy. Where local therapy with nystatin and voterzine B miconazole or clotrimazole is preferred over systemic therapy with ketoconazole or fluconazole because of resistance of Candida species to the later drug frequently occur. Well, to prevent the risk or relapse of the condition, the treatment with antifungal should be continued for more than 4 weeks, and if the antifungal are in the form of lozenges, the denture should be removed when the lozenges are in the mouth, and meticulous oral and denture hygiene is necessary. And when the denture is out from the patient mouth, it should be worn as little as possible, keeping them either in dry or in a disinfectant solution of 0.2 to 2% chlorhexidine at night. Well, in case of type 3 denture stomatitis, surgical elimination of the deep crypt is necessary, and also then this could be achieved either by laser or by cryosurgery. And an important thing that the oral candidiasis is the reflection of the patient's overall health. Well, this is another object, the traumatic ulcers and cheek biting. And usually these ulcers are commonly occur within a few days after placement of the denture, and they are characterized by a small painful lesion and covered by a gray membrane surrounding by an inflammatory hollow with firm elevated border. And the cause are usually overextended denture flanges or error in occlusion. As you can see, this is the painful ulcer result from uh, ill-fitted dentures, and the cheek biting may be the result of violation of the neutral zone or insufficient horizontal overjet of the posterior teeth, and it usually corrected by recontouring of the prosthetic teeth, or even if there is a major error, you have to reset the posterior teeth to have sufficient horizontal overjet. Another sequelae of wearing a denture is the denture irritation hyperplasia. And patients who wear ill-fitting denture for a prolonged period of time may develop denture, what is called denture irritation hyperplasia or apicus fissuratum. And this hyperplasia usually develops slowly over a long period of time from chronic low-grade trauma, and typically induced by unstable denture or an overextended thin denture flanges. This is denture hyperplasia, and the lesion may be small or it may extend to the entire length of the vestibule. Well, treatment are usually of two types. If it's small, you shift to the conservative treatment like adjustment or replacement or using of tissue conditioner, or if it is a big lesion, so the surgical excision of the hyperplastic tissue is mandatory in such cases. Well, hyperkeratosis and oral cancer. Although the majority of oral cancer develop in partially or completely a dentureless patient, but there is no evidence that the denture will cause these hyperkeratotic or oral cancer, but the conditions may be rather due to excessive use of tobacco or alcohol and frequent exposure to UV radiation, age, low socioeconomic status, poor dental health may be the predisposing to oral cancer. Well, we shift to the burning mouth syndrome. It is usually a sequelae of wearing a denture, and it's usually characterized by a burning sensation on one or several oral structures in contact with the denture. And the vast majority of these patients are old female patients more than 50, and they wears complete dentures. Well, the quality of pain in case of burning mouth syndrome is a burning sensation associated with a feeling of a dry mouth and altered taste sensation. The aggravating factor could be tension, fatigue, hot or spicy food, while it could be relieved by sleeping, eating, and distraction. It may reduce the pain intensity. Well, the etiological factors could be local factors such as mechanical irritation, allergy, oral habits, parafunction, myofascial pain, or systemic factors such as vitamin deficiencies, iron deficiencies, and so on, and the psychogenic factors such as depression and anxiety, and psychosocial stressors. Well, management of burning mouth syndrome. None of the proposed etiological factors should be excluded, and the denture wearer in whom no organic basis for the complaint is identified, the approach of the prosthodontist should be very careful, and the patient symptoms should be always be taken seriously. But any comprehensive prosthodontic treatment, including implant-supported overdenture, should be carried out only with collaboration with the psychiatrist and the prosthodontist to achieve good. Well, the gagging reflex is a normal, a healthy defense mechanism, and its function is to prevent foreign bodies from entering the trachea. And the gagging may be triggered by stimulation of the soft palate, the posterior part of the tongue, and the fauces. And in a very sensitive patient, the gag reflex may be released or initiated after placement of new dentures. And persistent complaint after gagging after placing of new denture could be due to overextended borders, especially at the posterior part of the maxillary one or the distal lingual part of the mandibular denture. Also may be because of poor retention of the maxillary denture. Pay attention to the occlusion of the patient and to the vertical dimension of occlusion, because increased vertical dimension and unbalanced or frequent occlusal contact may prevent adaptation and trigger gagging reflex. Well, in wearers of old denture, gagging may be a symptoms of a disease or disorder such as gastrointestinal tract disorder or adenoid or catarrh in the upper respiratory passages, alcoholism, or severe smoking. Well, we shift to another object, which is the overdenture abutment and associated caries and periodontal disease. Although the retention of complete denture is enhanced by an overdenture abutment, but there is a high risk of caries and progressions of periodontal disease uh, of the abutment teeth in case of poor oral hygiene. Well, one of the reasons for this is that the bacterial colonization beneath a close-fitting denture is enhanced, and good plaque control of the fitting denture surface is difficult to obtain. Well, one reason for infection of the abutment teeth of the overdenture is due to Streptococcus and the Actinomyces species type of bacteria. That Streptococcus will affect on the dental enamels, whereas the Actinomyces it will affect the root cementum, and both will enhance plaque accumulation. Well, for the success of overdenture, uh, we should have both mechanical and chemical plaque control. Mechanical by using brushing, and chemical plaque control by chlorhexidine and introduction of adequate wearing habits. Well, studies indicate that the use of fluoride chlorhexidine gel controlled caries development and maintains a healthy periodontal condition. So the patient should remove his overdenture and brush his teeth with this gel, as well as he should apply this gel to the fitting surface of the denture before he insert his appliance in his mouth. And these pictures show you peri-implantitis in the upper picture, and after good hygiene and periodontal treatment, the condition is resolved. And thank you for your kind listening.